This is Stacy State with Advantum Health. I want to welcome everyone to today's webinar. We have a great webinar today around coding, some of the pros and cons, and some of the main reasons for denials and what you might need to be on the lookout for in order to make sure that you are getting the money you deserve and that you're not getting unnecessary denials and other issues as it relates to your coding for your practice. So I wanted to go over, before we begin and before I introduce our speaker for today, a few just housekeeping rules here. So everyone will be on mute throughout the webinar. However, in your sign in for GoToWebinar, there is an area for questions. So throughout the presentation, if you have any questions, please put in your question in that area. We will either address them as we go, or at the very end, we're going to leave some time for questions as well. So without further ado, I want to introduce our speaker. So Parul Chandragiri is our Director of Coding and Physician Education here at Advantum Health. She comes to us with many certifications, including an MA, her CPC, CCC, and her CEMC. So I want to welcome her, and I will go ahead and give you presenting rights, Parul.
Yes, good afternoon, everyone, and thank you, Stacy. Appreciate that introduction. I am ready to take control.
Okay, I just turned it over to you, Parul.
Okay.
Did you get the...
No, I did not.
Okay, let me change it one more time. All right, you should get something that pops up on your screen. You should have controls if you want to start sharing.
It says waiting to view Stacy's screen.
Okay, let me... Okay, it should be moved over to you. Mine says waiting to view your screen.
Nothing here.
Okay, sorry, everyone on the phone. Let us...
Yeah, I apologize. I'm not sure.
Here, what we can do is I can share my screen, and then we can just...
Okay.
So 1 second, let me get your presentation up, and then I will just share my screen on my end. Parul, are you able to see my screen?
I'm just saying the coding advice for orthopedics. Now I can see yours.
Okay. Okay, and actually, okay. Is that better? Can you see the full screen now?
Yes, thank you.
Okay, perfect. All right, go ahead. Sorry about that, everyone.
Okay. Good afternoon, everyone, once again. Apologize for the slight delay and technical difficulties. So as the title that we have presented to you is for orthopedic and the best practices for, orthopedics, how we can maximize our reimbursement and reduce the number of denials. So the goal today that I wanted to bring to the forefront is those minor issues, the smaller details, which make a big impact on the entire revenue cycle management. And these minor details also focus on the documentation that would be provided, by the doctors, by the all level of providers, which would then thereby impact our revenue cycle. So if you can move on to the next slide for me, please, Stacy. Okay, this is just a disclaimer about, that all of the CPT codes, they are copyrighted and registered trademark of AMA. The information enclosed was current at the time it was presented, and Medicare and payer policies, they change frequently, so we always recommend that we check the payer's policy and reimbursement updates. The list of codes that we are going to present today, it's not a comprehensive list, and it is quite possible that there might be another appropriate code, but that depends upon the procedure and the services that were rendered and the documentation that was provided. The information that we've gathered is from Medicare and third-party resources, and it is subject to change without any notice due to frequently changing laws, rules, and regulations. And although every reasonable effort has been made to assure the accuracy of the information within this presentation, the ultimate responsibility for the correct documentation for services provided lies with the provider of services. And lastly, the provider of service has the responsibility to determine medical necessity and to supply appropriate codes and charges for the care provided. Next slide, please. Thank you. This is our agenda for today. We are going to briefly talk about the global surgical package, and then thereafterwards the decision for surgery and the use of Modifier 57, how it will be appended, what is the correct use and the inappropriate use. So we'll go over that. Post-op visits, especially CPT code 99024, and focusing on the musculoskeletal specialty. United Healthcare's changes in consultation code policy. This is just an update, a refresher, a reminder as to where we stand with United Healthcare's policy for consult codes. We already know that Medicare has done away with the consult codes. Next is the radiology changes for CPT 2018. Again, this will be a refresher. We'll briefly talk about the changes that occurred in 2018 and how they may impact the reimbursement. Thereafterwards, we're going to talk about closed treatment of pelvic fractures or dislocations, total knee arthroplasty, and lastly, trigger point injections. Okay, so the coding essentials. We all know that, coding, CPT code, they change every year. There are revisions happening every year. and we all need to stay abreast and up to date on all of the changes. And this should not be something that is done only, come October when we start getting calls from vendors selling us books. And by December, we get our training as certified coders or billers for what the changes are, and then we forget about it. But those changes that happen for the year, we need to periodically go over those changes again and again, because oftentimes we'll realize that many of the claims that were denied because of some old CPT code that was still there in the system somewhere, and it was sent out in the first quarter of the year or in the second, and sometimes, I'm afraid even in the third quarter of the year. So we need to make sure that periodically we do go over the changes for the current year. It is critical to understand the coding and how they apply to prior authorizations, to the documentation guidelines, and how they have their impact on the reimbursement process. Because oftentimes once, let's say, a new CPT code came up and our prior authorization pre-cert team takes that CPT code and reaches out to the authorization agencies and only finds that the authorization was denied or it went into peer review, and that only adds time. It adds important time from the time the order is placed to the time the authorization is gotten, and then going back to the provider asking them for additional information. So any kind of new change to a CPT code or a revision that is made, we need to make sure that all aspects of revenue cycle, right from the front end of the office till the time the claim is submitted, we are providing the accurate information and following the documentation guidelines so that the claims get processed and paid in the first pass. Train regularly and frequently your office staff. Include all the team members of your staff and also the providers. No one should be excluded. There should be no one on the team who should be excluded saying that, oh, they don't need to know because they are in the front end. Get them involved. Get your middle office staff involved. Get the providers involved. Hold weekly, bi-weekly, and monthly meetings so that, we identify claims that have prior authorization denials or any such other denials that would potentially have a direct, impact on the reimbursement and revenue cycle, and then come up with a plan to resolve these issues. It has to be done periodically and in a timely manner. So we need to come up with a well-structured plan on how to deal with the different denial buckets that we have. Next. Okay. Global surgery package or the global surgical package, it applies in any setting, including in patient hospital, outpatient hospital, AMSURG, which is the ambulatory surgical center, and also the physician's office. When a surgeon visits a patient in an intensive care or critical care unit, Medicare includes these visits also in the global surgical package. There are global surgical packages which are of 0 to 10 days, 10 days post-op procedure, and the 90-day post-op procedure package. And the NCCI edits Chapter 3 guidelines. They define a procedure has a global period of 90 days if it is defined, and that is defined as a major surgical procedure. Especially for our, CJR, that is the joint replacement model, CMS allows for surgeons or other practitioners to bill and be paid separately for a post-discharge home visit that was furnished in accordance with these conditions when related to comprehensive care for joint replacement model. All other Medicare rules for global surgery billing during the 90-day post-op period continue to apply. So here I have for us a brief outline of how the global surgical package is broken down. So the 0-day post-op period, it means examples given are like endoscopies or some minor procedures. There is no preoperative period for 0-day post-op package. There is no post-op period, and visit on the day of procedure is generally not payable as a separate service. And by visit, I'm referring to is the evaluation and management. 10-day post-op period includes the other minor procedures, not the endoscopies and not some of the minor procedures. Again, there is no preoperative period, just like the 0-day post-op period. Visit on the same day procedure is generally not payable as a separate service. And this part is often missed or miscalculated by the team, either in the coding or in the billing cycle, is that the actual total global period is 10 days. And then the way to count that is count the day of the surgery and 10 days immediately following the day of the surgery. Lastly, the 90-day post-op period, 1 day pre-op included, so the day before the surgery, that is the 1 day pre-op is included. Day of the procedure is generally not payable as a separate service. And then the total global period thereby is not actual 90 days, but 92 days. So we count 1 day before the day of surgery, the day of the surgery, and then the 90 days immediately following the day of surgery. And this breakdown, and there is additional information provided on this. I've included a link in here for this resource, Global Surgery Booklet, and it is a hyperlink, so you can click on it and use that to get additional information on the post-op period. Now, why does this become so critical or important when it comes to the surgery package is in the subsequent 2 slides. We shall take a look at it. The next slide talks about the modifiers that we would be using. And here we are focusing only on modifier 57 for the 90-day global period. And the reason is this makes a big impact because the provider has rendered services. They've given their, expertise. There is evaluation and management involved. And if the coding and billing team does not append modifier 57, there is a claim denial potential in there. So according to the CCI guidelines, if an evaluation and management is performed on the same date of service as a major surgical procedure, for the purpose of deciding whether to perform this surgical procedure, the E&M service is separately reportable, but we would append modifier 57 to the E&M service. However, any other pre-op E&M services on the same date of the service as a major surgical procedure are included in the global payment for the procedure, and that is not separately reportable. Modifier 57 is used to indicate an E&M service resulted in the initial decision to perform the surgery either the day before a major surgery or the day of the major surgery. Remember to append modifier 57 only to the E&M procedure code, where the decision to perform surgery is made the day of or day before a major surgery during an E&M service. And to apply modifier 57, which is decision for surgery, the E&M service must have led to the decision to perform the major procedure that follows. And by that, what we mean is there has to be documentation to support that the decision was made on the day before or the day of the major surgery procedure that was being ordered. There are several errors in how modifier 57 gets reported. And here are a few examples of the inappropriate uses of modifier 57. Remember, appending it to a surgical procedure code is incorrect, meaning do not apply modifier 57 to any of the CPT codes other than the E&M services. Appending to an E&M procedure code performed the same day as a minor surgery. And by minor surgery would mean either the 0 or the 10-day global surgery period. When the decision to perform a minor surgery is done immediately before the service, it is considered a routine pre-op service and is not billable in addition to the procedure. Do not report on the day of surgery for a pre-planned or pre-scheduled surgery. And lastly, do not report on the day of surgery if the surgical procedure indicates performance in multiple sessions or stages. This refers to those procedures which are staged procedures. So there is a decision made to do the surgery, and that surgery has to be done in stages, in 2 separate stages. We would not report modifier 57 for the second stage of the session of the surgery. Next slide, please. Okay, the post-op visits in 2018, and more specifically CPT code 99024. Now that we have briefly gone over what is the global surgery package, use of modifier 57, we need to then focus on CPT 99024. In July of 2017, the Centers for Medicare and Medicaid Services, which is CMS, began requiring medical offices with 10 or more practitioners in these 9 states: Florida, Kentucky, Louisiana, New Jersey, Nevada, North Dakota, Ohio, Oregon, and Rhode Island, and this was a random selection from the 50 states, to report claims data on post-operative visits furnished during the global period of specified procedures using CPT 99024, which is post-operative follow-up visit. Now, this kind of auditing requests were initiated by CMS because OIG had made a recommendation way back in May 1st of 2012 with the title Musculoskeletal Global Surgery Fees often did not reflect the number of E&M services provided. And in that recommendation, OIG found that Medicare paid $49 million for E&M services that were included in the global surgery fees, but not provided during the global surgery period way back in 2007. So as part of that OIG recommendation, CMS has been auditing any of the services which fall in the major global surgical package. And what they are reviewing is if practices are reporting CPT code 99024 and any other E&M service that is being reported in the global surgical package. And down below here, I have a snippet from the CMS's update in 2018. It reads, codes for which reporting on post-op visits is required. As of January 1, 2018, there are some changes made to the list of codes for which reporting is required. These changes are made necessary by changes in the coding system. The following CPT codes no longer need to be reported. CPT codes 15732, 34802, and 34825, these are deleted codes. Reporting of these codes is not required after December 31st of 2017. CPT codes 30140, 36470, and 36471 have a 0-day global period, so reporting is not needed. In case if you're not aware of this and you need a list of all of the 2018 codes that CMS has published, there's a link for you that you can access and find out if any of the CPT codes that your practice is reporting, if they are included in there, then there's the time for us to go back, review our, code sets that we are frequently using, and find out if we are meeting the guidelines for reporting CPT code 99024. There's also a link included at the bottom here. If you have additional questions about, it's kind of like an FAQ with answers regarding claim-based reporting requirements for post-op visits. Okay. Next slide was for United Healthcare. It delayed changes in consultation code policies. UHC had announced that certain revisions to the consultation services reimbursement policy would become effective for United Healthcare commercial members on October 1st of 2018. However, come October 2017, and they announced a delay in the implementation of this policy until 2018. Now remember, it's just a delay. We still haven't had any updates from United Healthcare yet, but the reason we are bringing it to your attention is keep a lookout. They might change it. They're surely going to change it. It's just that they've put in a delay. And this is what they have to say. We previously announced that certain revisions to the consultation services reimbursement policy would become effective for United Healthcare commercial members on October 1st, 2017. In an effort to give care providers more time to adjust to potential changes in their submission of procedure codes for consultation services, United Healthcare will be delaying implementation of the revisions to the reimbursement policy for services reported with consultation codes, CPT codes 99241 through 99245, and in the inpatient setting, it's 99251 through 99255. So please make sure that this is on your radar, and please do reach out to us too. We have your email, so in case if there's an update on this from United Healthcare, we will surely share it with you, and I've also provided a link that you can access and check on it periodically. 2018, we didn't have that much of revisions or changes to the musculoskeletal section, except that in the radiology part, there was something that could potentially impact the services that we are providing. Chest and abdominal diagnostic imaging services in the diagnostic radiology section of the CPT code set underwent significant changes in 2018. Here in this slide, you are seeing only the chest X-ray codes. I have not included the abdominal codes in here. Codes for chest X-ray are simplified. Up until 2017, there were 9 codes. All of those 9 codes are deleted and now are replaced by 4 new codes, which are based solely on the number of views. If you notice here in the deleted chest X-ray codes, in the description, you see there's the frontal, there's the lordotic, the oblique. All of those were the different wordings and the views that were required in the documentation of these chest X-rays when they were interpreted. We don't need them anymore. Not that we are recommending not to have them, but that is not required. We just need the total number of views. So these changes make it easier to accurately report X-ray imaging services based on the total number of views performed. Description of the type of view of the study is no longer a required element for coding documentation. Some physicians may prefer to continue describing the types of views performed, and that's perfectly fine for documentation purposes. We don't want, the templates to be rewritten or put, time in changing that. But what does require now is the number of views. That surely does need to get documented by the providers. If the number of views is not documented in the report, the coder should not assume that the reporting requirement has been met. Instead, the coder should work closely with the interpreting physician to clarify and obtain the appropriate information. This will help ensure that all pertinent information has been captured and that the claim submission includes the correct CPT imaging code. And what we've been noticing is that for a simple chest X-ray with the new CPT codes, if there is a denial and there is a request for documentation for a chest X-ray, once the documentation is reviewed, they uphold their initial denial, stating that the documentation does not support the level of service. And then upon further review, we find that the provider had not documented the total number of views, which is more important for the CPT reporting purposes versus, the actual views that are presented. Next slide, please. Okay. This is one such, again, very simple, very straightforward, and yet there are denials. And if your practice uses this or has had, they are fairly low in, the dollar value to it. But if they are doing more and more of these, what happens is sometimes in the AR cycle, we are busy chasing the large ticket items. And what happens is that the smaller ticket items don't get that much of attention. But then these are easy fixes. And if we take care of these CPT codes, then we will avoid these denials. And that way we can allocate our resources, time, and management for the big ticket item denials. So closed treatment of pelvic fractures or dislocations, CPT 27197 and CPT 27198. CPT 27197 is closed treatment of posterior pelvic ring fracture, dislocation, diastasis or subluxation of the ilium, sacroiliac joint and or sacrum with or without anterior pelvic ring fractures and or dislocations of the pubic symphysis and or superior inferior rami, unilateral or bilateral. And what is important is for us is the without manipulation part. And that's the major difference between 27197 and 27198. So 27198 is with manipulation, 27197 is without manipulation. Both these kind of pelvic fractures and dislocations, they represent a broad spectrum of injuries, but they are separated into two categories that are inherently stable and those that are unstable or potentially unstable. Injuries, if you notice here, I've underlined the posterior aspect. If there are injuries on the anterior, so when injuries are involving only the anterior pelvic ring, they are typically a result of low energy trauma like falling from a standing position, and they are usually considered to be stable. However, in comparison, injuries that involve the posterior pelvic ring, they are typically the result of higher energy trauma like motor vehicle collision, and thereby they may be unstable. And it is for this reason that these separate codes were established to differentiate the level of effort required to perform the two services and to align, the reporting of the current clinical practices. The services described by 27197 and 27198, they differ in the services that were performed to treat anterior pelvic ring fractures, which are now only reported with an E&M code. There is, if you look at the CPT code book, there is a parenthetical reference following CPT code 27197 and 27198, and it directs the coders, the users, to the appropriate evaluation and management codes to report isolated anterior pelvic ring fractures unassociated with an injury to the posterior ring fracture. So the example for 27197 would be like, a patient presents because of a motor vehicle accident into like with pelvic pain and with, pain when they are trying to lift weight or some activity that they are doing which has weight-bearing activity. There's imaging studies done, and they find that there is minimal displaced fracture of the anterior and posterior portion. In this case, the patient's fractures are treated without any kind of manipulation. That would be 27197. And example for 27198 would be where there was some kind of manipulation, let's say under non-local anesthesia. That's where we would use CPT 27198. So in a nutshell, if it's an anterior pelvic dislocation, CPT code books and CMS and AMA require us to report it with an appropriate level of E&M service code. Thank you, Stacy. Total knee arthroplasty. This too has some updates on CMS and in the OPPS final rule. These are the CPT codes. We have CPT 27445, 446, 447. And of that, 27447 is the total knee arthroplasty or total knee replacement. And then the two revision codes, 27486 and 27487. In 2018 OPPS final rule, CMS removed total knee arthroplasty from inpatient only list. And what that means is the procedure is removed from the inpatient only list. Some providers are now concerned that the younger, healthier patients will have the surgery as an outpatient, and that will, that there is a likelihood of it skewing the BPCI and the CJR statistics. So CMS responded to that, and in their final rule, they write that it does not expect a significant volume of such cases to shift from the inpatient to outpatient setting, despite being removed from the list, but they will monitor overall volume and complexity of cases to determine future refinements of the model. Additionally, CMS will prohibit recovery auditors from reviewing patient status for total knee arthroplasty procedures performed in the inpatient setting for at least 2 years. That is 2 years, that would be until 2020. And this is while providers gain experience with performing the procedure in the outpatient setting. The agency will permit reviews for other reasons, such as medical necessity. So keep a lookout for the total knee replacement arthroplasty codes and work with the providers in improving the documentation. There's additional information and the links are provided for each of those, the OPPS final rule, the CMS fact sheet, and then the AAOS has a very nice FAQ on that. Lastly, the trigger point injections. There have been quite a few denials, at least that's what we are seeing, and wanted to bring it to your attention. CPT code 20552 and 20553. So trigger point injection therapy is a common procedure performed by pain management specialists, orthopedic surgeons, physical medicine, and rehab, and other specialties. These are used to treat painful areas of muscle that contain trigger points or knots of muscle that form when muscles do not relax, for example, myofascial pain syndrome. What happens is that the nerves are irritated around them and it causes pain at the site of the trigger point, or the pain can be felt sometimes in seemingly unrelated parts of the body, including the back and neck. Trigger point injections involve injection of local anesthetic, saline, dextrose, and or cortisone into the trigger point. These are just a few coding tip reminders. There are, things that could easily be missed. So for CPT 20552, it's injections, single or multiple trigger points, one or two muscles. And 20553 is 3 or more muscles. Local anesthesia is included in these services, so please do not report them. Don't forget to report the appropriate J code for the medication injected, and imaging guidance. If that is done, if those services are rendered, those can be billed in addition to the injection if necessary using the following CPT codes: 76942, which is an ultrasound, 77002 fluoroscopy, and 77021, which is the magnetic resonance guidance. So all of the payers, especially with the Medicare and Medicaid services, they do not have a national carrier determination for trigger point injections. There are no NCDs for trigger point injections. However, your local MAC carrier could have, and in case if you don't have, I've included here all of the trigger point injections in a tabular form, the LCD number and the contractor name for your reference that you could utilize. Many commercial carriers also have, policies for trigger point injections. So please be mindful. It's very important to review your payer policies when performing these services, as it is not only the coding, but also the documentation and clinical indicators that need to be met for trigger point injections. So we have First Coast, we have Noridian, Novitas, Palmetto GBA, and Wisconsin. Each of these local carriers have an LCD for trigger point injections. Next slide, please. There's one more slide, Stacy. What the previous one? Thank you. So this is the tips and tricks. Remember to count the muscle groups and not injections to select between 20552 and 20553. For example, if the provider treats 1 or 2 muscles, report 20552. 3 or more separate muscles, only then can we report 20553. Report only 1 unit of either 20552 or 53 per patient encounter, regardless of the number of injections the provider administers. Please do not unbundle and report 20552 and 553 on the same day by appending Modifier 59. Documentation must support the level of service reported. The provider must clearly document which muscles were treated. Payers are likely to reject claims based on documentation review that fails to note the muscles treated and rather has reference to only the number of injections. In other words, provider must document the exact muscles that are injected. For example, I treated deltoid muscle with 3 injections. That's the kind of documentation that payers are looking for. Or I injected 3 different muscles, and then they would, document which muscles, either in the shoulder or in the back or the neck. Next slide, please. These are all the resources that were used for this presentation, and links are also provided for the NCCI edit and the Medicare Claims Processing Manual.
All right, thank you, Parul. I'm going to take back over for just a minute here. As we go through the next slide here, feel free to submit any questions in that question box, and we will get to them in just a second. So go ahead and, as you comprehend everything that Parul just walked through, feel free to submit those questions. I just want to go over a few of the other services. So Parul runs our coding, as well as we do a lot of coding audits here at Advantum Health, and she runs that department. So if you're ever in need of coding audit, any kind of coding advice or services, Parul is definitely our expert in that area. We also do a comprehensive revenue cycle. So we have billing, prior authorization, AR management, denial management, anything and everything to help with your revenue cycle from your front office to back office. We also help with consulting services. So I know a lot of you all are probably in the midst of MIPS and macro this year with reporting for being prepared to report for 2019. So we also have experts that will help not only select the right measures, the right reporting that you need to do, but also submit those reports on your behalf. Also, any kind of payer negotiations for contracts, etc. So we help a lot of our clients manage those aspects as well. And then lastly, just some of the dashboards and analytics that go along with that. So we use those not only for our internal reporting, but also to give back to our clients so that they can know how their own staff is performing, and where the benchmarks are and how to move forward and with some of the best practices. So that really concludes our presentation for today. I'm going to open it up for questions. Again, feel free to submit those questions. Parul, thank you for your wonderful slides and all the information you shared today. I will be providing the presentation in PDF after this webinar. So be on the lookout for that to come to your email. Okay, I will leave this open for a minute or two in case we have some questions come through. If not, we definitely thank you for your attendance and hope you have a good rest of your day. Thank you, Parul, for your time. I think I'm going to go ahead and shut the webinar down.
Okay, thank you, Stacy. Thank you, everyone. Enjoy the rest of the day.